Good evening, everyone. Thanks very much for joining us for this webinar which was prompted by a recent NIHR announcement and article, I think, in BMJ about the lack of efficacy of PPIs in patients with throat symptoms. And this is something that's been kind of close to our hearts for probably about 18 months now. We've been trying to think of new ideas and new ways that we might want to look at LPR patients. So we thought we'd put together a webinar. It's fairly informal. I say we've got 44 registrants, but everyone will be joining at different times. So we're just going to crack on with it. We're going to record it. And if there's only a few participants, then we'll just open a live Q&A. People can raise their hands. Or if people want to put the questions in the Q&A box, then that would be great. And if anybody wants to put anything in the chat box, that would be great. I'll be monitoring that during Kinesh's presentation, and he'll be doing the same vice versa. So without further ado, those of you who don't know Kinesh, he's a consultant gastroenterologist at Chelsea and Westminster in London, and he's going to start the ball rolling with an introduction to this concept. And over to you, Kinesh.
Great. Thank you very much, Anthony, and thank you for asking me to present tonight. I am going to talk a little bit about this whole treatment area. And I think the first thing to say is that this is a challenging area and that always causes a bit of consternation and angst in the people seeing these patients. I'm going to talk a bit about the treatment options at the moment, and I'm going to hand over to Anthony, who's going to give us the bombastic bit about the novel diagnostics and treatment approaches, and what we should be doing or what we should think about, should be considering doing in the future. And then Marcus is going to end with the $64,000 question that we're always asked is surgery the right way to go for these patients? And that should hopefully give us a bit of light about that, because it's something that comes up again and again and again. Okay, so as I said, this is often how people feel. It's how GPs feel, it's how I often feel, and I'm sure it's how ENT surgeons feel as well when faced with these patients who have troublesome symptoms. And hopefully during this talk, we'll get a little feel of why that is and why we all, patients and the physicians, will feel frustrated in this arena. So what are throat symptoms? So these are the common things that people present with. It's pain, globus, pain when they're swallowing, recurrent coughing, throat clearing, difficulty swallowing, or changes in the voice. And they're all slightly different, but patients always localize them to the throat. And they sometimes ascribe their symptoms to reflux. Are they right? Are they wrong? Who knows? But people complain about these things. They're often very debilitating for the patients. They cause a huge amount of anxiety, and people suffer them day in, day out, and they don't know what to do. And they seek medical attention. And that's probably one of the reasons they become quite so frustrated. So in general practice surveys, if the GP asks people about throat symptoms, a quarter will say they've got throat symptoms. So these things are incredibly common. I don't think there are many conditions where you get 25% uptake in the general population of people attending general practitioners for their athlete's foot or anything else. And 6% of middle-aged women have globus. So these are big numbers when you translate these to a population level. And these throat symptoms have been made analogous into LPR. And I'm not an ENT surgeon, but it's something that I work closely with ENT surgeons all the time. And this is one of the dilemmas, because throat symptoms don't necessarily equate to LPR. And this is one of the reasons that patients get frustrated, because they're not actually sure what's going on. So LPR is when you get reflux from the stomach up into the larynx. And why is that? Why does that cause a problem? Well, reflux itself is when gastric contents move at an abnormally high level into the esophagus. And we know that people with LPR have higher levels of reflux, about 40% of them, on a background of 20% in the general population. So reflux is more common. But what we do in the esophagus, or what the esophagus does, is it's stratified epithelium. It's much more able to deal with this acidity coming up. The larynx is not the esophagus. Of course, that's true, but the epithelium is completely different. It's the columnar epithelium. It's much more sensitive. And there are some studies showing one bout of reflux or gastric contents or bile or pepsin or anything moving up in there can cause damage to the larynx. So we know that that part of our body is exquisitely sensitive. And is it that is the problem here? And is it that that recurrent damage is what's causing the problem, and the throat symptoms and the persistent clearing and everything else that's causing so much anxiety and difficulty? And we know things like bile, if it's there, cause high pH refluxate, and it's got enzymes and agents that really tackle that very exquisitely sensitive laryngeal epithelium. And you can imagine the larynx is highly innervated, and if there's anything wrong there at all, we would expect that we would feel it all the time, and that's what these people complain of. So what could it be? So this is a differential diagnosis. Is it postnasal drip? Is it something in the nose? Is it that they've got a behavioral problem, throat clearing? Are they smoking? Are they talking too much? Do they have verbal diarrhea? Is it an environmental problem? Is it stress? We have to be upfront about that stress certainly can manifest itself, just as it can do in the joints or the muscles or the stomach, or with diarrhea. It can also manifest itself in the throat. And that is one of the differentials, and one that's particularly difficult to address. Or is there something going on, and is the larynx being sensitized, and that's causing the problem? And once we consider all of these things, everyone feels like this all over again. We feel like this, and the patient thinks, like, what do we actually do? And therein lies the challenge. So on a practical level, the patients that we see in secondary care are not the ones out there with the majority of the problem, just like everything else. And we have often this ivory tower view of things, whereas most of this is managed by general practitioners. So most patients are diagnosed there by their GP based on their symptoms alone. And those symptoms are different. If they have dysphagia, of course, they need to come and see a gastroenterologist and have an endoscopy and all those sorts of things. But if they've got pure throat symptoms without anything that makes you think, look, this might be cancer, then the GP will often initiate some sort of treatment themselves. If they see an ENT surgeon, they will do a flexible laryngoscopy, nasendoscopy, and if they see us, well, we will scope them, but we all love scoping. But if I'm completely honest, I'm not sure that has a huge yield, and whether it actually moves the patient further forward in terms of their diagnosis and improving their symptoms is unclear and unproven. We may do a pH catheter study to look for reflux. Is there reflux coming up? Is that a useful test? Or if the patient can't tolerate it, or they don't want it, and lots of people feel like they don't want a pH catheter study because of the fear of discomfort, then a wireless pH study, is that helpful? Again, that's a good test for reflux, but is reflux the driver of these symptoms, or is something else going on? And so pragmatically, what has been done for many, many years is give them some PPI. Could it be reflux? Reflux is a bit more common in people with throat symptoms, so let's give them some PPIs, and let's see how they get along with that, and let's push the problem down the road. So, as I said to you before, gastroesophageal reflux and LPR, they often coexist. They're 40%, and we can get 50 reflux events in the esophagus, and that's normal. But people are showing 1, 2, 3, 4 reflux events up in the into the larynx can be pathological and cause inflammation and symptoms. And there's this debate about whether acid is needed, but we know that you don't necessarily need acid if you have bile coming up into the throat. And we all we know from if you see someone with a biliary stoma, bile is one of the most caustic substances that we have. It's up there with feces. You get feces on your skin, it'll burn. If you get bile on your skin, it'll burn. You can imagine that if you're getting bile in places where it shouldn't be, like the throat, then it is going to burn there too. There's no reason why it would be any different, particularly in an area of the body that is so exquisitely sensitive. So why is this done? So there have been lots of studies along the way, and this is an old one from 2007, and they took 49 patients and with throat symptoms, and they did a pH catheter study on all of them, and they found that 27 of those had abnormal levels of reflux in the upper esophagus. So they gave them some esomeprazole, and they did it again. And it worked in 22 out of 27, which is a good marker of how good esomeprazole is at decreasing acidity. But out of the other 5 that didn't have decreased acidity, 4 of them felt better. So something else is going on here. It's clearly not just an acid problem. And given it's not an acid problem, people have thought, done small studies, uncontrolled studies along the way saying, oh, well, PPIs seem to work. I've taken my 12 patients and 8 of them felt better, so PPIs are a good thing. And so this group published this large multi-center study, a pragmatic real-world study, which I think is the way to go. And increasingly, certainly journals like the BMJ want to see real-world data rather than ones from tertiary centers. And they looked at PPIs to see, could they help treat persistent throat symptoms? And it was 8 centers, 350 patients, and they had unexplained throat symptoms. So hoarseness, throat pain, globus, clearing, cough, or choking. And these are all common symptoms, and they were evaluated, and they had a reflux symptom index, which I'll talk about on the next slide, and they had flexible nasal endoscopy as well. And this is the reflux symptom index, and people rate it themselves 0 to 5, depending on how bad their problem is with those issues: hoarseness, clearing your throat, swallowing, coughing, breathing, and all the things that people find difficult when they're dealing with this. And you can see that there's 9 items, 5 each, so that comes out of 45. And what they did was they analysed this one of 2 ways, because you could get, you can get 5 marks just for having simple chest pain without any throat symptoms. So they took 2 markers. One was just this out of 45, and one of them, they just eliminated the bottom one. So that was just what they called the RSI HB, which will be important later. And the HB indicates nothing to do with heartburn in it. And they looked at those outcome measures saying, did PPIs help? And if they were on a PPI, they had a 4-week washout, and then they were given a high dose of lansoprazole, 30 milligrams twice daily for 16 weeks with a matching placebo. Because in this setting, there's been no studies looking at one PPI being better than another. And 27% of people receive PPIs in the last 12 months, and that's relevant because, again, it's a practical real-world study, and we know that PPIs are commonly used in general practice to deal with a multitude of symptoms. And at the end, this is always interesting and something often not mentioned in papers, but really gives you a good clue about how good the drug is. So only 42% of people on PPI guessed that they're on PPI, and 56% guessed in the placebo group. So no one really knew what they were taking, and there's not, and that gives you some idea about what the results are going to show. So these are the scores, and they've looked at the reflux symptom index. As I mentioned, they've looked at when they've taken away the heartburn score, they've looked at other reflux scores and a quality of life score. And essentially with all these scores, what you need to essentially be aware that the higher the number, the worse the symptoms are. And you can see if we look at the top red box, that actually at 16 weeks, both groups have improved significantly from 22 to 17.4 and 15.6. And then at 12 months, both groups have improved again. And that goes for every single one of these measures. So essentially, everyone got better on PPI or placebo treatment. And their very practical conclusion was that lansoprazole really didn't help over placebo for patients with persistent throat symptoms in a true randomized controlled trial. And the downside of this was there was no reflux testing. So, we don't know if having reflux changes whether lansoprazole or PPI would be helpful. But in a pragmatic GP type way, actually giving people PPIs for throat symptoms is probably unhelpful. And that led the NIHR to issue this alert saying, don't give out PPIs willy-nilly to GPs. And so, what next? Because that's really to put the kibosh on what people have done. Because it's easy to write a prescription. It's easy to send the patient away saying, try this for at least 3 months, maybe 6 months, and come back and see me again. And what next is what I call the ascetic plan. And that is very different to the ascetic plan, which means drinking plenty until you've got ascites. No, this is the ascetic plan, living like a monk. Okay, and if we have a look at LPR diet on Google, you can see there's 106,000 results for that. So people are interested in this, and people are interested in diet and lifestyle changes. So stop smoking, less caffeine, no peppermint, even no decaffeinated tea or coffee, no acidic or spicy foods, dropping the pH in the larynx if pepsin can be activated, smaller meals, don't exercise for 2 hours after eating, don't eat or drink for 3 hours before sleeping, lose some weight. And all this is good lifestyle advice, but the quality of evidence for all of this is very, very poor. It's observational. No one's looked at this in a methodical, systematic way, but we do it because we think it might make a difference. But we're pretty sure it probably doesn't make very much difference, and people essentially don't want to follow this, so they say that they're better. So we're back to this differential diagnosis. Which one of these is it? Is it something else? Should we be doing something else? And what do I do in my practice? I often think about things backwards. And I think at this stage, often we think, what are the reasonable medical options? What treatments do we have available that could be useful? And because that's all we have, we either do nothing, or we give them some medicine, or we do some sort of procedure. And to my mind, the treatment options here are, it's either baclofen, which reduces transient lower esophageal sphincter relaxation, but it's complicated by sedation. Neuromodulators, for which there is a little bit of low-level, low-quality evidence, tricyclics, gabapentin or pregabalin, all of these have been published. I often use nortriptyline for a minimum of 3 months because that addresses many of the differentials of hypersensitivity and assess, does that make a difference? And that can help people, and making sure you've got the right dose and titrating it upwards is probably helpful too. But I think that for me is often my next step, but it is a grey area, and there certainly is no high quality data behind that assertion. And then they come back. So what next? Do we do speech therapy? Do we do some more testing? Do we send them off to psychologists for CBT, or that's all done online now? Or do we have an operation? And the answer to that is we don't know, and that's why I'm going to hand over to Anthony now to hopefully shed some light on some of these conundrums.
Thanks very much, Kinesh. So we don't have any open questions. If anybody wants to ask a question directly, they could turn on their video, raise their hand, and we can do that. Otherwise, I will ask a couple of questions myself, and then we'll move on. So Kinesh, in terms of using neuromodulators, one of the things for using neuromodulators in IBS is that about 30% or more of patients can't tolerate the side effect profile. Do you find the same in these LPR patients?
Yeah, absolutely. And that's why, amitriptyline used to be the rage, but actually I find the majority of people couldn't tolerate amitriptyline due to sedation. Nortriptyline is better tolerated. There's certainly less sedation with it, but even then people have issues with palpitations and sometimes sedation as well, and feeling of depersonalization. But I'd say the majority of people can tolerate it. But again, with all these things, there is a placebo effect, and no one's looked at this in a systematic, rigorous, controlled way. So, but we aren't left with many medical options. And what do we do when we're not left with medical options? We use things with low quality evidence, and that's what we're doing.
So we've got a question here from an attendee asking any role for Gabascon Advanced.
So yeah, I think Gabascon is probably the thing with the best well, I'm not going to say evidence-based, but the best hypothetical evidence in that, we know that PPI, what people have done in the past is use PPIs and then add in ranitidine or cimetidine or something else like that, which we know now is pretty hopeless, both partly because H2 blockers are affected by tachyphylaxis. So, they affect wanes after 3 or 4 weeks anyway. And there's, again, another placebo effect there. With Gabascon, there is a barrier function that's forming that raft and actually coating the larynx if there is damage caused by reflux from the stomach. And if that is the diagnosis, is likely more helpful than any of the other strategies. And also, there are no side effects with Gabascon. So it is probably the best bet here.
I've got another question, but just before I move on to that, there is a product called Zivarel that we were looking at that is, I think it's marketed by Norgine, and it's hyaluronic acid in sachets, which seems to have some use in European studies, but not much in the UK. We did ask if they were interested in doing a study, and they weren't, strangely. But that's another thing that we tried empirically with patients as a kind of coating for both the larynx and pharynx and proximal esophagus. So the only problem with it is it has quite a lot of artificial sugar in it, so it has a quite high xylitol content, and from my talk later, that might have its own problems. So this question is from Mahmoud Wahed. He said, who should investigate and manage LPR, ENTs or gastros?
So I think a little bit depends on who they present to. I think with the NHS, the way it is, sending someone to another specialty, at least when we know that the initial management of this is fairly straightforward. So it should be the person that sees the patient. It can be the GP, it can be ENT, it can be gastroenterology. I think if they're coming up from the GPs, then they should probably go directly to ENT, but they're in front of us. Then I think as gastroenterologists, then I think we take the lead, and only if symptoms are refractory, they go off to ENT.
Great. So there's a comment from Craig Vickery. Are you happy to give this group a diagnosis for LPR at this point? I think what he means by that is, do we say they're LPR-like symptoms, or, we'll probably interject during this study, because we specifically talked about throat symptoms rather than LPR with the title of this, but at what point would you consider giving someone a diagnosis of LPR?
I think LPRs, they have to have someone look down and say there's evidence of damage here. And there's a scoring system for ENT surgeons that they'll be able to talk about more than me. But, I think if on a pragmatic level, not everyone who has all these symptoms can see an ENT surgeon. There isn't that capacity in the NHS. So there has to be a more pragmatic way of trying to deal with this and filter out the ones that need to see an ENT surgeon.
So another question from me, when PPIs first came on the scene, 30 years ago, we were doing some of the early studies, and the concern for us all at that point was that these were going to become lifestyle drugs, and people wouldn't, lose weight and do all these different things. They would just take their PPIs and carry on as normal. And of course, it's been very convenient because they're so effective in drugs. Do you think it's going to be hard for people to break the habit if they see a patient with throat symptoms to still go down this road, even though the guidance is fairly clear?
Sorry, I'm not sure. I didn't catch that. Sorry.
So I'm just saying, do you think it's going to be hard for people to break the habit after so many years of prescribing?
Yes.
PPIs?
Yeah. I think that is that. There's no doubt about that. And also, it's an easy option, isn't it? To give a prescription for a drug. So take this medicine. We hope you'll feel better. I'll see you in 6 months. That is much easier than dealing with all the other issues.
And I think this is mirrored by Rami Spice's comment here, saying, despite this study suggesting there's no difference in response, there's still people who do respond to PPI, and should we not give those an opportunity to respond if they're going to?
Well, so I think that's what I said, actually. So, everyone responds. So instead of giving them PPI, you should give them a placebo, because we know that they respond at the same level. That's what the study shows. And all the previous studies have been low quality, probably hampered by selection bias and everything else. So yes, they do respond to a PPI, but they also respond to placebo. So we have to have a mechanism of dealing with that doesn't involve dishing out active drugs to people who will respond if we don't give them an active drug.
Okay, just checking if there's any more questions. Okay, so I think we're okay. So I'm going to hand over control of monitoring the questions and comments to Kinesh. And I think there's one more question that's just come in. Is there any role, this is from Dan Cartledge, any role for prokinetics?
No role for prokinetics at all. I mean, the issue with prokinetics as well is that most of them have significant issues with toxicity if used long-term. Domperidone, azithromycin, metoclopramide, which has a black box warning in the US. So, we try to minimize use of these anyway. And if you've got a long-term problem, these don't work anyway, but even with people who do benefit from prokinetic, we try to minimize their use. So no on every level to that.
And one final one for me, in terms of the physiology, which is obviously closest to my heart, most of those studies didn't use physiology to correlate with response to drug. Is that the biggest weak point of most of these studies, that you're not actually identifying those people who got reflux before you try and treat them for it?
So I think that's right. Although the first study they did identify people with reflux, and they showed that those, who didn't have a response to reflux treatment still got better. So there's something else here.
Okay. So I'm going to close that down. And I'm going to share my screen. Okay, can you see that okay?
Not quite yet, just give it a second. Yep.
Great, so as I said, we've been thinking about this for a while because we've been scratching our heads why patients have such severe and life-affecting symptoms and are really persistently seeking medical help, and yet we can't see what's going on. So we've been exploring the literature and looking for alternate explanations. And this presentation was something I gave at the European Foregut Society a while ago, just to be a little bit disruptive about putting culprits and what else might be causing reflux beyond stomach acid. So if it's not about bile, but in our experience, bile reflux is actually quite rare. We did a lot of studies back in the day, as we say. I'm getting on a bit now with things like Bilitech, and it was quite rare to see true bile reflux. But the concept I want to introduce today is about the fact that not all gastroesophageal reflux is equal, and what might we be missing. I want to talk about digestion and fermentation, about the process of that and the byproducts. And I'm going to introduce the concept about the proximal colon and gastroesophageal reflux as a forgotten mechanism. We're going to talk about the microbiome and GORD, and is there a relationship, and explore the concept of whether excessive gut fermentation can explain why LPR rarely responds to PPIs. Future GORD therapies, should the proximal colon be the next target? And a call to arms for refractory GORD and LPR, that we should change the way we look at these patients and try and measure different things. So fairly out there, but try and bear with me. So how to test for LPR? There's really no consensus. Should we do the same as we do for GORD? We've got here the Lyon consensus, but it doesn't really cover anything to do with LPR. So what we really need is objective testing with a twist, and we need to sort of set up a new set of parameters that give us new guidelines for looking at these patients with predominantly throat symptoms. So we can use multi-channel pH and impedance monitoring. And there are new catheters, not so new catheters, but catheters have been around about 5 or 6 years now, that actually allow you to put both impedance and pH sensors in the proximal esophagus as well as in the distal esophagus. And the way you do that is you first do a manometry, you look at anatomically where everything is, and then you can choose different lengths of esophageal catheter to get the best fit. So that when you put the pH probe up in the just above the esophageal sphincter, then you've got the best fit to keep the pH probe in the distal esophagus around 5 centimeters above the lower esophageal sphincter. And Kinesh talks about normative values. With the proximal reflux episodes that you can measure with impedance, we have established normal values. And with the pharyngeal and laryngeal reflux episodes, as he pointed out, even one reflux event into the pharynx in healthy subjects is considered, in patients is considered abnormal, because you just don't see this in healthy controls. And this is what a pharyngeal reflux event looks like on impedance. So you've got here the baseline impedance dropping in a retrograde way. And the purple that you can see on the bottom panel here is just a color plot, and purple represents low impedance, blue is gas. And here you can see red, which is acid reflux going up. And I'm going to talk about that a little bit more. And the three types of tests I'm going to talk about are esophageal and pharyngeal pH and impedance, the ResTech acid probe, which sits in the pharynx, and just normal gastroesophageal pH and impedance. So just to orientate you to the what you're going to see, red is acidic, light blue is non-acidic pH, purple is low impedance, so usually liquid, navy is high impedance, which is usually air or gas, and the only other thing we look at is whether it goes up from the stomach or down from the mouth. So this concept of not all reflux is equal. If you've got stomach acid, which is full of hydrogen ions, it's highly ionic, what you get here is a drop in pH, strong drop in pH, below pH 4. So this is around about pH 2, coming up into the esophagus. And you get a very strong impedance signal, so a dark purple pH signal coming all the way up into the proximal sensors and then sitting there. And you can see here the patients press their regurgitation button at the same time. So that's a typical acid reflux event coming up into the proximal esophagus. But we also get non-acidic reflux. So what is non-acidic reflux? It could be just a combination of diluted stomach acid, diluted with a meal. It could be potentially bile, but I think most commonly it is kind of diluted stomach acid in the postprandial periods. And what you can see here is you get a much lower drop in pH, so to about pH 5.5 or 5, and you get a weaker ionic signal here. So the impedance is still low, but it's not as low as it is with an acid reflux event. We also get gas reflux, which is blue. And so instead of seeing a drop in impedance, we see a spike in impedance. And that's usually associated with belching or transient lower esophageal sphincter relaxations. But the concept I want to talk about here is weakly acidic and weakly ionic reflux. And I'll show you about this a bit later. All of the parameters that we use for our pH impedance studies are based on measuring these stomach acid events. But if you've got something else happening, so here you can see these little drops in pH that are occurring, but nothing much in the impedance range. What we've begun to do is to try and figure out what these drops in pH are, because they quite often correlate with patient symptoms, but they're not low enough to register. And because they don't have an impedance signature low enough, they don't come up as a positive correlation. So what we've started to do in our patients is to make the sensitivity of the impedance a little bit more sensitive. And lo and behold, what we started to see is that these low, so these weakly acidic events have a weaker but definitely significant impedance signature. And I'm going to talk about that in a bit more detail. So going back to possible mechanisms, we know that digestion and fermentation causes a large amount of bacterial activity. So what happens here, all the nutrients in the small bowel are passed through, they get absorbed. The things that are hard to digest go into the colon, and because there's lots of bacteria in the colon, then we get lots of fermentation and we get lots of goodness from that secondary metabolism of those difficult to digest, mainly carbohydrates. If you get too much bacteria in the small bowel, then that fermentation occurs much higher up in the process and causes symptoms, and that's small intestinal bacterial overgrowth. And if you get the wrong type of bacteria or you get carbohydrate malabsorption in the colon, then you get excessive gas production. I think the concept that Mark Pimentel talks about is that small intestine is a bit like your dinner plate, and the colon, proximal colon, is a bit like your waste disposal unit. So you don't want a dirty dinner plate, and you want your waste disposal unit to process things. But the proximal colon is a fascinating region. It's a bit like a second stomach. As I say, we get lots of secondary nutritional and chemical products from the breakdown of non-digestible carbohydrates in this region. It's got a rich blood supply, and it's got a rich bidirectional neural input from vagal and spinal afferents going up and down to various regions in the brain. So it's a fairly complex region doing an incredibly complex job with trillions of microbes and lots of nutrients to process. And some of the byproducts of that include short-chain fatty acids, but also gases. So things like hydrogen sulfide, methane, hydrogen, things that we can measure from breath tests. But you also get lots of other things such as bioactive compounds and volatile organic compounds. Now, thinking about pH 5 is a pH that we recognized in the proximal colon to be important. This is a smart pill stool drops off, but this is the pH in the terminal ileum here at pH about 7.9. And when it drops into the proximal colon, then we get a drop down to a minimum of about pH 5. The reason it doesn't drop below pH 5 is because at that level, bacterial fermentation arrests. And that's when you start to get a buildup of carbohydrates in the colon. You get an osmotic drive, and then that leads to bowel movements and loose bowel movements. So pH 5 is quite important, and that's what occurs due to short-chain fatty acid production in the colon. And can we measure some of these compounds in the GI tract? And this is studied from George Hanna, who's been taking to show, he's been doing work trying to look at biomarkers of cancer, but what he's been able to show is in both mixed breath and bronchial breath and in gastric endoluminal air that you can pick up all sorts of short-chain fatty acids and other products of bacterial fermentation. And there is a machine called a SIFT machine, which allows you to look at these things in real time, which will be bringing along to the BSG this year. And what we've done here, this is just me. I had a curry in the morning and at lunchtime, looked at my fermentation, and we could look just by breathing into the machine, we can look at these samples. So methane, which we're normally able to pick up, also hydrogen sulfide and acid. So it is possible to pick up these different products in breath. We're doing an even more detailed study now using adsorbent tubes, first of all in healthy volunteers, and then we're going to move on to IBS patients. But this allows you to collect breath samples over 10 minutes and really concentrate volatile compounds onto these tubes, and then do a huge amount of analysis to see in over 1,000 compounds what might be relevant both at baseline and in stimulated states after you've introduced a meal or a fermentation drink. And the other elephant in the room is salivary pepsin. We know that PEP test has been around for quite some time. We know that pepsin can be active at pHs below about 6. So it doesn't have to be super low for pepsin to be active. And the PEP test, which is just spitting into a tube 3 times during the day, has shown reasonably good sensitivity and specificity with pH monitoring. And 75% of patients with LPR had salivary pepsin compared to asymptomatic controls. But none of these tests are super sensitive at the moment. I think there's much room for improvement. But I think the message is there's a whole witch's brew of chemicals that aren't stomach acid that may be coming up into the pharynx and causing problems. And giving PPIs to block these compounds are not going to work. So proximal colon and GERD is a forgotten mechanism. So communication within the gut is bidirectional, and certain chemical triggers can modulate gut functions both proximally and distally to the stimulus. And a classic example of this is with fat in the distal small bowel that triggers the ileal brake to aid fat absorption. But the fermentation of carbohydrates in the colon and short-chain fatty acid production has a similar effect, and the distension from intestinal gas has a similar effect on gut reflexes. And we think this may be responsible for a different type of GERD, which is both poorly treated by PPIs and may actually be promoted by their use. So this is a study from 1996, which I certainly missed first time round, but shows some really elegant work in healthy volunteers. This is using a gastric barostat, which where you keep the volume, the pressure constant, And if the volume goes up, it means the stomach's relaxed. If the volume goes down, it means the stomach is contracted. And when they put different concentrations of short-chain fatty acid as well as lactose into the colon, then we got a stomach relaxation. So the high concentration of short-chain fatty acids in the colon, you got a bigger stomach relaxation. So the proximal colon can speak to the proximal stomach and cause a reflex relaxation. And this was also correlated with breath hydrogen. So as fermentation and gas go up, and that comes out of the breath, then that you get a subsequent decrease here. So what they did in these patients is to give a high FODMAP diet versus placebo diet to healthy volunteers. And what they showed is that transient lower esophageal sphincter relaxations were higher both at baseline and after meal in patients who were on a high FODMAP diet. And at baseline, the healthy volunteers had much higher baseline gas production, and it's still higher after meal. So there's a relationship here between FODMAPs in the proximal colon being fermented and effects both on the proximal stomach and on transient lower esophageal sphincter relaxations. And they did do pH monitoring here, and they showed that postprandially, there were 23 reflux episodes overall on placebo, and this increased to 35 on high FODMAP. And there was also increased symptoms of heartburn and regurgitation. And again, here it shows the reflux episodes going up in virtually all of the healthy subjects. And if this is in healthy volunteers with an intact hiatal complex, this is likely to be amplified in GERD patients. But this was very much forgotten. Now, we looked at the microbiome and GERD and if there was a relationship in patients referred for anti-reflux surgery. And this was work by Jordan from our group in Manchester. And using a hydrogen methane breath test, Jordan showed that about 60% of patients had an abnormal breath test, either for bacterial overgrowth, intestinal methane overgrowth, or a combination of the two. And overall, patients with a positive reflux association for symptoms such as regurgitation also produced nearly double the amount of gas. And this was published recently in Surgical Endoscopy. So there's definitely a relationship between issues with the microbiome, fermentation of carbohydrates, and reflux. So we wanted to objectively measure this a bit more. And I know ResTech has a little bit of bad press in the past because some of the pH changes were shown actually in patients with gastrectomy. But what we saw in a lot of these LPR patients was not very much reflux during the day, but we got this nighttime drop that suspiciously sat around pH 5.5. And I inquired with the company and some experts about this, and no one could really explain what it was. And it doesn't actually show up as significant on their Ryan score, which is their kind of equivalent of Demister score, as a significant event. But being a physiologist, trying to figure out what this pH change is, it looked like some kind of fermentation product to me. So we started looking back at the pH traces of people who've had both of these tests done. And sure enough, you can see just little changes around to about pH 5 occurring quite frequently at night. And when we increase the impedance sensitivity, again, you can see the purple here, which is evidence of liquid coming up, weakly ionic, weakly acidic reflux coming up. So what we think is happening here at nighttime is that there are some regurgitation of non-acid, but possibly fermentation-related products. Now, this is one for Kinesh, that one of the things that I hear at least twice at every MDT is that this patient clearly has the SSRI deficiency syndrome. And, I absolutely know that there's going to be very similar symptoms here. No pH changes with the normal sensitivity impedance, and no pH or impedance when we increase the sensitivity. So it may be that this type of patient is the one that might respond. There's definitely no evidence of traditional reflux or this different type of reflux. And therefore, this might be a patient that would respond better to a neuromodulator, for example. So how is this different? The thing is that liquid reflux rarely reaches beyond the upper esophageal sphincter, because when liquid reflux comes up, then you trigger all sorts of vagal reflexes that protect the upper sphincter and the throat from that reflux coming up into the throat. It's a dangerous, noxious substance, and the body knows to protect against it. However, venting of gaseous reflux through the oropharynx and larynx via belching is completely normal. So when you get this type of reflux, then everything opens up to allow it to come out. And then what happens when that happens? The chemical contents of this reflux is quickly cleared during the day via swallowing. So you belch, you swallow, you clear. So you've got a defense mechanism against it. But we rarely swallow at night. So if these transient lower esophageal sphincter relaxations and gaseous events are happening at night, this weakly acidic and weakly ionic passive belch-related reflux could be driving these gases just to get through swallows. So how do we measure them? Where's the evidence? Then, so an acid reflux event, it sits in the proximal esophagus and then gets cleared. With our LPR probe, what we can see here are these frequent weakly acidic events that are coming all the way up into the pharynx here. If we increase the sensitivity of the impedance, you can see that they're sitting in there a long time, basically because the patient isn't swallowing. You can see a swallow here, you can see a swallow here, but then nothing for, up to several hours while people are in deep sleep. So a guy in Australia has taken this to the next level, and they've used reflux scintigraphy in patients with LPR. And I'm not going to dwell on this too much because this is fairly experimental and they've not done sort of control studies. But by using a labeled substance, then they can objectively measure reflux into the pharynx and larynx using scintigraphy. And they can actually look at this in lung aspiration as well, is what I want to say here. So you can see things, and we've all had patients who say this reflux is going into my ears, and we've kind of said, well, that can't happen. But these studies are showing that actually, possibly this can happen. So just to summarize that last bit there, we think that weakly acidic and weakly ionic reflux, possibly due to dysbiotic fermentation, can be commonly detected at night with Res-Tec and pharyngeal impedance if the sensitivity is increased. Normally, this would be vented as a belch and quickly neutralized by swallowing, but this clearance does not occur at night when patients are asleep, and the long exposure to potential irritant chemicals could be causing the problem, both in people with throat symptoms, but I think as well a big population of patients with respiratory disease. PPIs may make this worse because PPIs can often make dysbiosis worse. As shown from the study with Jordan, but prospective studies are obviously needed to explore this further. Now, talking about treatment and speculating about potential treatments, then the Australian gastro we talked about here has been doing studies looking at the distended right side of the colon, and he's been treating this with prokinetics and laxatives, and some Gabascon, but rarely PPIs. The data is pending on his study, and it'd be really interesting to see, but he's convinced that treating this region actually helps reflux in the proximal regions. This is an old study from John Hunter, and what John was able to show was that you can reduce fermentation both with treatment of antibiotics, but almost as impressively with a low fiber diet. So this is the equivalent of the low FOD. So trying a low FODMAP diet or a low fiber diet in these patients might also be a really simple way to see whether you can improve symptoms. So instead of going the whole lifestyle change, then cutting down on fermentables might be useful. And there's all sorts of other potential targets with short-chain fatty acid receptor antagonists that might come out in the future if we can prove this mechanism is, one that is, potentially treatable. So the call to arms really for refractory GERD and LPR is to go back to your impedance files, turn up the sensitivity and assess those nighttime periods. Because if we've all got hundreds or thousands of people who've been for these studies, so the easiest thing we could do is a retrospective analysis to see if this is common, and then we can design some prospective studies. If people are doing Res-Tec, check for nighttime drops. Don't ignore them just because the Ryan score doesn't register them. These might be important in people with throat symptoms. We definitely recommend using a general bowel symptom questionnaire. We have a questionnaire got in development at the moment. In over 300 patients referred for a hydrogen methane breath test for GI symptoms. 58% of them so far have throat symptoms as well. We think we should perform a lactulose breath test in the majority of these patients. And I really think we should try and set up a UK working group to try and explore these concepts further, which was hopefully something we're going to do through AGIP and some of the other committees with the BSG. So I'm going to leave it there and stop sharing and see.
Great. Thank you very much, Anthony. That was really insightful and certainly a lot of new things there and certainly food for thought. Any questions from anyone? Either raise your hand or type away if you've got anything to ask Anthony. Oh, I've got a question. And do you think it's practical to introduce this on a widespread basis in the NHS? Are there the people and equipment out there to actually deliver this?
Well, if we can prove the concept in secondary and tertiary care, then treating throat symptoms with, for instance, a low FODMAP diet, it might be a starting point. And if that then turns into a low fiber diet or a modified diet that people can identify triggers. At the moment, people think the triggers are things that are irritant, that might be things like alcohol or caffeine or fizzy drinks or spicy food. But actually, if that's more like garlic and onions and things, and actually the symptoms are caused at night, then maybe it's worth trying that. I think if a patient doesn't respond to diet, a bit like an IBS patient, then doing a breath test on them and treating them like a SIBO patient might also help. But if you think about the evidence that comes out about how PPIs, can lead to increased risk of gut infections, and also, the translocation of oropharyngeal microbiome into the colon, which will cause dysbiosis, then treatment with PPIs, this could kind of explain why they don't work and actually might make it worse in some people. So treating it as a potential as a microbiome or dietary related disease caused by fermentation, it's a fairly new concept, but it would be fairly easy to treat. I mean, a low FODMAP diet isn't difficult for people to try.
It's incredibly difficult for people to try, but the concept isn't difficult. The practicalities are very challenging for most people. But I accept what you say is right, of course, that it's an easy intervention.
And doing a breath test is fairly simple for most people. It could be done in primary care as well. So there's a lot of work to do. I think we just need to work on this from a kind of clinical science point of view to prove the concept. And then look at some randomized trials, which we will be doing, I think, in the next 6 to 12 months in patients with predominantly with IBS, but I think we will have to move to a kind of LPR study at some point.
And we've got a question here: are we missing inlet patches?
That's your job, Kinesh.
So yeah, I mean, I think inlet patches are certainly something that can be associated with globus. No one's conclusively proved that treating them on a randomized basis actually helps. And we know that they're there for a long time. People get symptoms at a certain point of their life. And certainly there's papers showing that you can improve people's symptoms. But again, it's a bit like the PPI story. So yes, you may be missing inlet patch, but I think the firm evidence for widespread testing for that is still to be published. And I think there are a couple of trials ongoing at the moment that should help address that will hopefully report in the near future. Okay, well, I think then in that case, have we got this all wrong? Has Anthony got this wrong? Have I got this wrong? Should we just be saying to Marcus, please, these people just need an operation and then they'll be cured and all this is nonsense? So I'm going to hand you over to Marcus Reddy, consultant upper GI surgeon at St George's, who's got a very big reflux-based practice, and I'm looking forward to hearing what he has to say.
Thanks, Kinesh. Let me just check that you can hear me and that you have video now. I'm going to share a screen. If you can activate that, please, Anthony, so I can do screen sharing. Are we able to activate the screen sharing?
It's done.
Done. Okay, great. Great. Okay. Right. Can you see that? Kinesh, is that visible, the screen sharing?
No, not yet.
Okay, why has that not come up? Okay. Share. Is that sharing?
Yeah, I've got your whole screen. Yeah.
Yeah. Is that good?
Perfect. Thanks so much.
Yeah, thank you. There's so much science going on from Anthony and Kinesh, and surgery, lots of the things we do are quite slightly less scientific. I think the tradition of the fund application, which has been going on for 60 years plus, we still don't have really strong randomized control trials with all the other techniques, but there's definitely been a massive resurgence for thinking about other options, in particular endoscopic. And that's because over time there's been development from the old assumption that basically you either use PPIs for GERD or LPR, which obviously more recently we now know that for LPR it's less useful, PPIs, or you go down the surgical route. That's been the traditional view. But obviously the last 15, 20 years, we've seen more and more concern about the use of PPIs, which has made people consider much more the option of undergoing an intervention. And as a result, there've been a lot more development. So a lot of people have heard about the obviously complications of reflux surgery, which there are many side effects and complications. And the follow-up for the Nissen shows that there's also a durability issue, because it's not just good at controlling reflux for a short while, but over years it seems to hold. And then ultimately, over many years, it really does become much less successful. So I think the option of surgery, it's still appropriate in some patients, but we have to be aware of all the side effects, complications, and the durability issue. And I think a lot of the data that surgeons have been looking at is using the traditional HRQL type questionnaires, which is predominantly traditional GORD type symptoms. So when we follow them up, we use these rather than the RSI, which is much more LPR type symptoms and throat type symptoms, where the patients have cough and hoarse voice and these types of symptoms, which obviously are much more difficult to manage. But I think because we've grouped it all together, the outcomes, we don't distinguish very well with interventions between LPR and classic GORD symptoms. And ultimately people have thought, well, what's the alternative? Well, the principle of the Nissens effectively is to correct any diaphragmatic, so external weaknesses, and which is effectively the external lower esophageal sphincter. And the link similarly is about reducing these transient relaxations of the lower esophageal sphincter from external. And I'll talk a bit about stretta, which is much more about the internal muscle development, all really trying to, I think, try and control these transient relaxations which occur and allow reflux to come up. I mean, the other issue is probably gastric emptying, which we know is significantly associated in reflux patients and will promote reflux as well, especially during these transient relaxations. So the Nissen, ideally, we believe helps create a new sphincter. It's not quite a one-way valve, and we all know of patients who have significant dysphagia, weight loss, bloating, but it does control reflux really quite well. The reason of, all these other things like links and stretta and TIFs and all these endoscopic techniques exist is ultimately because the Nissen isn't perfect based on its side effects, complications, and durability. There are problems with links as well, of course, which can involve the actual foreign body device either not being fixed in the open position because of scarring and leading to ongoing reflux, or in the closed position where it would of course develop dysphagia, but it can slip as well in the road. So it's neither, that's not perfect either. But we do know that when you compare them, they do have fairly good control of pathological reflux compared to each other. I think that the side effect profile is quite different. And of course, all this data really is HRQL, which doesn't separate the throat type symptoms, the ones which the patients may complain of, with hoarse voice and sore throat or postnasal drip type symptoms. But we can see that really the HRQLs of both have fairly good long-term follow-up. We don't have such good data quite for Stretta, but it's still more than 10 years worth of Stretta data now. But we can see, you know, compared to using PPIs, it's not bad doing anti-reflux surgery. I'd say that Stretta, where we do an endoscopy and put radiofrequency into the lower esophageal sphincter, above and below the junction level and in the cardia, works primarily on the sort of submucosal area where there's probably some degree of fibrosis and some muscularis hypertrophy of the internal sphincter. And I think that most of us would believe that its function really is primarily to reduce these transient relaxations, which help promote reflux. And there have been some interesting studies to show the levels within the wall of the esophagus about the hypertrophy of the muscle before and after Stretta. It takes many months, so you know, patients often get a transient improvement for a few weeks after the procedure because they have some temporary edema, I think, from the needles, and then that settles and their reflux comes back, and then they go on to get improvement. And when we say improvement of reflux, that can be reduction in medication, better control on medication, and less so coming off medication. I'd say that my experience, it's more about 30% will actually come off medication, but they will, 3/4 will get improvement in some way. So we can see the degree of hypertrophy you see within the internal sphincter layer. So there is quite good data going over a decade now for Stretta, but if you look at most of the data is actually all, in a way, traditional Gord type quality of life surveys. We don't really have quite the same quality when it comes to the throat type symptoms. It's not separated well, but it is believed that, for example, there's some good data now supporting Stretta for LPR as well. But I see Stretta, you know, part of it sits between this medication and surgery. It's not necessarily an alternative to surgery, especially if they've got a hiatus hernia, who I think that surgery still significantly helps those patients. I mean, it's been reviewed endlessly, and I think Stretta now has got fairly good support, having been considered a bit experimental and novel. It's now part of the repertoire of procedures for reflux, and in the US, it's been used over 250,000 times, I understand. But I think that it's still in its early days from the point of view of knowing its exact role, whether it's used in isolation, together with PPIs, bridging between surgery. I think it does have a role, but I think we have to be selective at this stage with Stretta. And, you know, I tend to select patients according to the standard reflux, pathological reflux on pH manometry. I'm always cautious about the LPR patients, and I will warn them that I feel it's significantly less successful for LPR, even though some of Professor De Guerra, who's done over many thousands in Italy, would strongly support it for LPR. I'd say it definitely doesn't, in my hands, have the same success rate as for classic reflux symptoms. But you can use it after fundoplication, which is quite useful. Patients who've had fundoplication many years before, I do use it sometimes if they're finding that they are now getting recurrent reflux. It's proven not to be useful in the bariatric patients. I think that bariatric surgery changes the anatomy and physiology of the upper gut so significantly, it's hard to assess any role for Stretta in post sleeve or bypass patients with reflux. And there's certain patients you wouldn't use in, and specifically it's the hiatus hernia patients who've got significant diaphragmatic defects. I'd be reluctant to use Stretta, but I think its role fits somewhere within the range of bridging between PPIs and surgery. Obviously, the number of patients wanting to come off PPIs has meant a lot of slightly optimistic and hopeful thinking that Stretta would get them all off it, but it doesn't for a lot of patients. They often get better control, but it doesn't get them off their PPIs often. So we've tried bariatric patients and I've had no success with it. And I don't think many people have either. So my personal strategy is patients with the significant hiatal defects where there's anatomical disruption. I think that they need an anatomically correcting procedure in the hope that it improves the function. The LINX patients, I've actually started using in patients with bigger hiatus hernias now that it's much more established. You know, there have been people who use it post-bariatrics. I tend not to, because I think that there are usually other reasons in bariatric patients why they're refluxing, such as degree of stricture formation or angulation in the stomach, which reduces the gastric emptying. So I think that using LINX in that should be done with caution. And Stretta is useful in those who can't avoid to have surgery. But I think that giving them the expectation is extremely important, whether they're going to get a good success or not, because even though it's non-invasive, I think there's clearly a group who won't benefit. We've been using it with Kinesh's assessment in patients with lung transplant with some success. I'll just mention TIFs because there is transoral incisionless fundoplication surgery happening in London. And I think it's still at its relatively early stage, but I think it may well have a role in future. It can't be used in revision because of any distortion in the anatomy. But I think it's one technique which, you know, I'm watching closely as a potential future endoscopic technique, which also does some anatomical correction, which Stretta can't. Any questions?
Marcus, while people are thinking, there's two things there. I mean, you know, this mechanism of, you know, which I talked about, you know, right-sided colon increasing the sensitivity to transient lower esophageal sphincter relaxations and so forth, is exactly why I think Stretta has always, the company itself has always paired with Restek. So they've always thought that there was this kind of pepsin-related disease, and in fact, in America now they have the pepsin thing. So they've kind of pushed this hypothesis without putting any science behind it. Are you aware of any studies that are kind of ongoing or are in the pipeline to kind of, you know, tie together the physiology with the outcomes from Stretta rather than, you know, beyond the typical kind of reflux measurements?
Yeah, I mean, nearly all of it is still about quality of life surveys and like the RSI questionnaires. I think the transit relaxation, the problem is it's delivered in different ways in different countries. And I think that where Stretta has been used, for example, in parts of Europe where it's prescribed, so there are parts of Europe where patients on PPIs who want to come off can be prescribed to go and have a Stretta. It's not led to very good data beyond quality of life surveys. And the physiological studies have been fairly lacking. But I think it's going to be time before we get good data on Stretta more than quality of life surveys. But I think for the, I think the strategy of seeing it as part of sort of managed investigation assessment, including, for example, breath testing and dietary change, especially for the LPR patients, really useful. But I don't think we can see Stretta as, you know, the sort of as a primary treatment at the moment. I think that, you know, they need a lot of assessment before. I mean, usually these patients who come for Stretta will be partly managed with dietary change, low FODMAP. They will have breath testing, and many of them have LPR, and they're looking for a non-surgical procedure. So, you know, if you could do some more work on it, it'd be really helpful.
Yeah, no, I think that's the point, because at the moment it's fail on PPIs, go to the surgeon. And I think that's the work that we've done with, you know, some of our upper GI surgery colleagues, is to try and understand a bit better about patient selection. Because, you know, if the number one symptom or number two symptom after Nissen fundoplication is gas bloat, then is it just due to the mechanical obstruction, or is it just because they're producing too much gas? And you know, people hadn't really thought of it in that way before. And it's just trying to engage our brains a bit more about, you know, that patient selection process. But doing any kind of randomized controlled trial with these different mechanisms and including physiology is so incredibly difficult and laborious that you know, it remains challenging.
Yeah, I think that it strongly supports the sort of MDT approach with physicians and surgeons working together, because you know, it's quite easy for a patient to jump from PPIs to asking for a surgical opinion, when actually, you know, the thorough workup, going through all the options, including all the different interventional options, is really helpful. And I think some of these patients, I'm sure you've seen them with SIBO, and who've actually done quite well with non-interventional methods of management. Or patients who've had surgery and actually subsequently do quite well once they've been fine-tuned with diet and sometimes antibiotics and sort of non-surgical interventions.
So just to keep the physiology thing rolling, you mentioned a little bit about gastric emptying. You know, there's been quite a few studies recently that have kind of said that gastric emptying testing, you know, is either fast, slow, or normal, but doesn't, you know, correspond very well with symptoms and everything else. You know, how do you use gastric emptying in terms of, you know, predicting outcomes for surgery? You know, do you look at things like pyloric outflow and you know, is it due to the hiatal defects? How do you use sort of gastric measurements to sort of help with your patients for surgery?
Sadly, most of the time it's an afterthought after surgery when they develop side effects of gas bloat, or they don't respond well to the anti-reflux procedure that most of us then start investigating. I think if there are clues prior to considering an intervention, then it is useful to do gastric emptying studies, even though there's a big variation in norm. You know, the traditional gastric emptying studies, I think that because of the wide range of whether they're truly delayed or not, is still difficult for us to really interpret. Some patients will be having surgery when they have gastric emptying problems, and that inevitably leads to either poor reflux control, for example, after Nissen. But there's some evidence, strangely, that Nissens actually improve gastric emptying, even though you'd think to the contrary. At the same time, most patients, I think, who have stretta also seem to have some slow emptying afterwards. But we don't normally investigate gastric emptying as part of their workup, but I think maybe we should be considering it much more often before we commit them to a procedure. Kinesh, how do you, before you consider referral for intervention, try and pick up those who've got poor gastric function?
So I think because a lot of the patients I send to you have cystic fibrosis and diabetes, and is often poorly controlled and have had it for a long time, the high index of suspicion in that cohort. I think if there are no upper GI symptoms in a sort of standard patient, then I'm not overly suspicious. But in that group, I think if there are symptoms of early satiety, vomiting, or just heaviness, postprandial heaviness, then I think now I have a fairly low threshold for doing a gastric emptying study, just so we can inform the patient a bit more about the risks of surgery and what that may entail if things don't quite go according to plan.
Because I think that if we consider the transient relaxations, in those patients with any degree of gastric emptying problems, they are going to have quite exaggerated symptoms, aren't they? And potentially they will be the high-risk patients for gas bloat. And
that's one of the reasons that I think, in cystic fibrosis particularly, where bloating is the #1 gastrointestinal symptom overall, and that's why fundoplication is not a good option. In the groups, the cystic fibrosis groups, they're saying don't have a fundoplication, to each other.
Yeah. I mean, one thing which has, I think, has become more common is not just in salvage situations, but in patients with severe reflux, is effectively diversion with a Roux-en-Y bypass. And that, of course, will minimize the issues of gastric emptying because the stomach's, the proximal pouch is tiny, so you're not really relying on gastric emptying. And at the same time, it's a very low pressure system. And I think that, that is a valid salvage option if we think there is significant delayed gastric emptying. We don't often see it high on our sort of thought processes as an option, but you know, physiologically it makes sense to have something which has excellent stomach drainage combined with a low pressure system and an exclusion of most of the stomach juice and bile. What do you think about it's a little bit radical, I suppose.
I think when there's good evidence for it, it's good. You know, there's evidence for it in patients with dysmotility, systemic sclerosis, as a revision option. As you say, you know, there's no chance of relapse. So I think there are a lot of pluses. It's a bigger operation, and you know, I think it's particularly useful in people who are overweight. I think if they're overweight, it's a no-brainer because I think it sorts everything out in one go and cures their diabetes and sorts their reflux out, and you know, they end up being happy afterwards. In other settings, it's more difficult and it's a patient-related discussion. But you and I both see patients, you know, all the time. We've had 1, 2, you know, 3 eosinophil applications, and you know, they're back again, and that's not a good position for the patient either. So you know, it's informing the patient and working out what they're prepared to undergo, and whether they know that, you know, there's a chance in 10. You showed your graph at 10 years, 40% have got symptoms again. You know, are they willing to have another operation 10 years down the line? That's the question, isn't it? Yeah.
And I think one thing that we've now realized also is that when we do it for reflux or room-wide bypass, they need the similar guidance as patients who are having it for obesity surgery, in the sense dietetic support, nutritional and vitamin support. I think that sometimes when we do it for reflux, they've not passed through that sort of route. But when I do it, you know, I think it's important that we advise them as we would any bariatric type patient, because they will need the ongoing guidance and nutritional supplements.
So Kinesh, as you started this, I'm going to just finish off with just a question to you. I mean, we did one of these webinars just on traditional gastroesophageal reflux, and Phil Woodland presented a very, you know, eloquent algorithm for how you treat reflux patients and so forth, and you know, how you subclassify them. But no one seems to want to take ownership of LPR and throat symptoms. What do you think is needed for us to get to that same position in terms of having that test, treat algorithm that we need for patients with throat symptoms that are going to make a difference?
That's easy. That's an effective treatment. The reason no one wants it is because it's difficult to treat. And that's why, you know, I had 3 identical slides of, you know, the head and the hands. That's the reason. So it generates a lot of work, but there's no clear consensus on what to do that actually is meaningful. So, you know, we've given us PPIs. We now know that that's not helpful, particularly, you know, if there were a clear dietary strategy, if there were a clear medical or therapeutic option, guided maybe by diagnostics, maybe not, then that would be a game changer, and people would welcome those patients because they could offer them something meaningful. And that's satisfying for both the patient and the doctor.
Okay, great. Well, we're going to wrap up there. So thanks for everyone for joining. As I say, we'll send a link round for anyone who wants to watch this offline. I would just want to thank Kinesh and Marcus for giving up their evening. Much appreciated, and hopefully it's going to raise some debate, and it certainly is going to help me focus where we want to take our R&D efforts in the future. So thanks once again, everyone, and have a great evening, and I hope you can join us for our next one.
Thanks, Anthony.
Thank you very much.
Thank you. Bye, Kinesh.